Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, fully occluding earwax, just commencing with their left ear, which the patient felt was the worst one out of the two. However, it proved that the right one was a lot more difficult for me to remove, so do stay tuned for that. And the consistency of the wax between ears also differed significantly, and maybe in part that was one of the reasons why the right ear was a lot more difficult. The left ear was slightly soft, but nonetheless the wax was together. It wasn't loose. It was firm enough to bind together, which always helps. If the wax is too loose or sticky, when you suction it or try and remove it, it comes out in little bits and not in large lumps, so it can make it difficult to remove. You can see we've already cleared the majority of the ear canal. The patient's just got some wax in the inferior recess. So this region where I'm in now, we call that the inferior recess. As we approach the eardrum, the ear canal narrows. You can perhaps see that narrowing. Where I am here, the ear canal, you can see it narrows, it comes inwards. And then after it narrows, it widens again, and that creates a little pothole, if you like, a little recess where I was just getting that wax out inferiorly to the bottom of the ear canal next to the eardrum, and also to the front part of the ear canal, the anterior aspect near the eardrum. We call that the anterior recess. And I'm now just mopping up some wax, dead skin. So the wax plug that the patient had was enveloped in some dead skin. And you can see some skin here that's still attached to the ear canal. It's died, it's shedded, but it hasn't migrated. And we're right near the entrance. And we know we're at the entrance because you can see the hair strands. These hair strands that you can see, the little whiskers on the screen, they should only be located on the cartilaginous portion of the ear canal, which forms the outer third. The outer third of the ear canal, the cartilage portion, the layer of skin that lines it is your typical type of skin. It's got three layers. You've got the epidermis layer, the outermost layer. You've got the dermis layer, and then the innermost layer called the subcutaneous layer, which is a layer of insulating fat and connective tissue. And it's in the dermis and sometimes also the subcutaneous layer where you normally find the hair follicles. The ear canal deeper in the ear, the medial part, the inner two-thirds, the osseous portion, the bony part of the ear canal, the skin that lines the bony part of the ear canal doesn't contain the dermis, and it doesn't contain the subcutaneous layer. It only is lined with the outermost layer of skin, the epidermis. And that's why you should never really find any hair follicles or strands protruding on the bony part of the ear canal. So the left ear is done. Now we can move on to the right ear, and this ear was a lot more tricky. The different consistency, the wax and dead skin, there's a lot more dead skin in this ear. The higher concentration was extremely hard, almost stone-like, and this can happen in between patients' own ears. So quite often you can get a patient who has soft wax in one ear, in the contralateral ear they have hardened wax, just like this patient, so it's not uncommon. So I'm trying to use the hook to glide over the roof of the ear canal, over the wax plug, and once I glide over, and then rotating the hook clockwise by 90 degrees or so in an attempt to embed the tip of the hook into the wax and keratin plug, and then I can slowly remove it. Now, although the surface of this plug was hardened, the core of it was actually quite soft. So as I was rotating the hook, instead of extracting the wax and keratin plug, the tip of the hook just dissected through the wax and keratin plug, and instead of removing it, it just cut it up into little pieces, which can sometimes be helpful because I can then go back in with the microsuction tube, like I am here, to vacuum out some of the loose fragments of the wax. And you may have seen there, I was trying to lift the bottom part of this plug off the floor of the ear canal, but it's really embedded. So I've reached out for the forceps as well, and I'm going to try and get the bottom jaw underneath this. You can see I've got a good angle there to work with, and I'm lifting it up, trying to detach it from the floor of the ear canal, but the skin that's attached to the ear canal and the plug is extremely adhesive. It's holding this wax in place. It doesn't want to let go. So now I'm going to enter with the hook. I'm going to go underneath and then rotate it anti-clockwise. I'm trying to get underneath it and scoop it up so I can separate it, which I have. And now I'm going to the back part of the ear canal, and I'm going to rotate it clockwise, trying to bring it through. This ear was slightly narrower near the entrance as well, which made it a bit more difficult. So again, just trying to get the wax plug from underneath and lift it up and away and off the floor, trying to mobilize this wax plug. Quite often when you're performing earwax removal, you're preparing the wax so then you can later remove it. It's not always about trying to remove it immediately. I've realized here we're going to have to loosen it, detach it. So I'm just trying to go all the way around. I'm now to the back part of the ear canal, and I'm trying to bring this wax and keratin into the center. By bringing it into the center, we're bringing it away from the side ear wall canals. And now I've reached out for the Jobson horn. I'm just going to go over and behind and trying to leverage this out. As I'm bringing out the Jobson horn, I have to accommodate for the curvature of the patient's ear canal. Otherwise, the Jobson horn will just make contact with the ear canal wall. So our ear canals are not straight cylindrical tubes. They have bends and twists, widenings and narrowings. And when you're in the patient's ear, you get a better perspective of their anatomy. So every time I'm bringing this Jobson horn out, I'm maneuvering it around the bends and twists and accommodating for the widenings and narrowings in this patient's ear canal. So I think I've managed to remove the lateral plug of wax and keratin. So anything beyond the second bend, which is where we are now, the canal to the right there, that's the second bend of the ear canal. And where you find the second bend of the ear canal is where the cartilage portion of the ear canal meets the bony part of the ear canal. We call that the osseo-cartilaginous junction. So when you're working around the second bend, you know you're not too far from the bony part of the ear canal. And as I discussed earlier, the skin that lines the bony part of the ear canal is extremely thin. It's less than 0.1 millimeters in thickness, so we do have to be very careful and gentle when we're working on the bony part of the ear canal, because if you do make contact with the canal wall, it hasn't got much of a buffer because the skin's very, very thin, and the bone is not flexible and malleable like the cartilage. It's rigid and it can be very uncomfortable, so it's going to be gentle. So bringing this out in large chunks now, another huge piece there. If you watch till the end, you'll see a still image and you'll see all the wax and keratin that are removed. And the patient has got quite long hair strands near the entrance there, a bit longer than the norm. And it can sometimes, you can see there the whiskers, it can slightly obscure the view, but I'm still able to remove this, clear this ear out. So again, I'm just going to go over the top and slowly bring it down. And you can see that there's a little opening now through the wax and keratin. So at this stage, the patient, although there's still a tremendous amount of wax and keratin in his ear, you could feel an instant relief because the sound can now travel through the ear canal, through the opening. And you can see why this plug was quite difficult to remove. It's lined with this very thick blanket of dead skin. So in order to remove this wax plug, we need to detach the skin, but it's very tough and strong. And you can see it extends all the way deep into the ear canal near the eardrum. And I'm I'm just going to give it a little wriggle. We're going to separate this big plug from the sheets of dead skin. You're just holding it deeper in the ear. You can see it's tearing at the bottom there. And eureka, we managed to bring that out. So the eardrum's fully visible. The patient's just got some dead skin now, and he did experience some clarinetting. So when you suction dead skin, the skin violently flaps at the tip of the sucker sometimes, and it can emit a very loud, almost deafening high-frequency squeal. Not only for the patient, but it's also extremely loud for myself. So at this stage, we were getting some clarinetting. I decided to put some olive oil into the ear just to soften the skin, to see if it helps me to remove it without it clarinetting. I'm just suctioning some excess oil out there, and I've got a better purchase, but we were getting some clarinetting, so I advised the patient I'm going to leave that skin. Although it's there, it's not significant, it's not going to affect the patient's hearing. And I was just asking them if it's okay, whether they're okay, because there was a bit of clarinetting. And I'm just mopping up some excess oil now. I've just bent the end of the suction probe so I can get access into the anterior recess in the right ear. That's all the wax, dead skin, keratin. You can see a lot of these wax plugs have coated with dead skin. It's enveloped it. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Thank you, bye.